My name is Henry Budenchain. I'm a Senior Capacity Building Coordinator at Health HIV. Thanks for joining this breakout session. We're excited to have Ben Turley here and also Dr. Kimberly Henderson. I'll do a brief bio and then we'll turn it over to them for their presentations. So Ben Turley is with the DC Department of Health. He is an epidemiologist at the CDC Foundation, working at the DC Department of Health. He's worked in the DC area for over 5 years, first as a psychiatric counselor at the Psychiatric Institute of Washington, and then by studying substance abuse trends as a researcher at Georgetown University, where he received his master's in systems medicine. At DC Health, he now investigates non-lethal opioid overdose and employs novel surveillance strategies like cluster reporting, risk modeling, and emergency response quantification. Dr. Kimberly Henderson is also with the DC Department of Health. And Dr. Henderson has over 18 years of strategic health and risk communications experience. She serves as the director of the Office of Communications and Community Relations within the District of Columbia's Department of Health. Prior to joining DC Health, she was an associate with Booz Allen Hamilton, where she directly supported federal clients with planning, implementation, and evaluation of outreach efforts for health, well-being, and employment initiatives. She also led several efforts on behalf of both civil and military health clients to reach a variety of stakeholders, including healthcare providers, policymakers, beneficiaries, service members, veterans, and the general public. She has also used her communications, health disparities, and public health knowledge, experiences, and skills in the classroom. She has served as an assistant professor in the Doctoral Communication Program, Masters of Public Health Program, and Department of Family and Community Medicine at Howard University. An instructor in the Krieger School of Arts and Sciences, advanced academic programs at Johns Hopkins University, and an adjunct assistant professor in the Department of Medicine at Georgetown University. Dr. Henderson received her BA in Mass Communications from Dillard University, an MA in Journalism from the University of Arkansas, Fayetteville, and a PhD in Mass Communications with a health communication focus from Howard University. So Ben and Dr. Henderson, thank you for being here. I'll now turn it over to you, Ben, for your presentation.
Hey everyone, I'm Ben. I'm an epidemiologist at the CDC Foundation. I was brought on specifically to cover non-lethal overdose in the district. So I'm investigating surveillance, understanding how people use, where they're located, and then the behavior when they do. So we can really understand the best prevention strategies and then get a better idea of how this disease progresses. So in this presentation, I'm going to be first going over the state of substance abuse in DC, how we compare on a national level, and then sort of go through the demographics so we can understand the problem specifically. From there, I'm going to talk about what I've been working on recently these past couple months, which is understanding the spikes in overdose, why those happen, and then what we can do with them. I'm going to touch briefly at the end on where those spike reports go, and then I'll leave it to Dr. Henderson to cover the communication aspect of that. Okay. I think we're gonna have some time for questions at the end, so we can save those for that. Okay. So everyone understands that DC has a drug use problem, but as of a couple weeks ago, the CDC released new data from 2020 that found that of all jurisdictions in the United States, all states, DC has the highest mortality rate, period. For opioids, DC is ranked second. 81% of all opioid, or of all drug use deaths are the result of opioids. And you might be wondering, what is making up the difference? Why is DC number 2 for opioids, number 1 overall? And that reason is cocaine use. Sorry, it looks like a repeat slide. Okay, cocaine use. The stimulant of choice in DC for a long time has been cocaine or crack, the derivative. And a lot of other areas where opioid use is a problem, meth is the stimulant of choice. Sorry, I'm not pressing any buttons, just doing that on its own. I'm not controlling the slides here. I'll keep going. Okay, great. So neither of these things are good to take, period, and doubly so when you're also taking an opioid. The important thing to consider here is that cocaine use makes up almost a third of all opioid deaths, is on board for about a third of all deaths. And that means that there is co-substance use, so people are doing two things at the same time, which is never a good idea, and especially so because one of these things is a stimulant, the other is a depressant, and it makes your central nervous system confused, and it results in a heart attack or respiratory depression. For all you statisticians out there, you might think, well, you know, DC is not a good comparison to the rest of the states, so I pulled out all the counties in the United States for a better comparison for drug mortality. And you can find that DC is still top 5. The only jurisdictions beating us are San Francisco, Franklin County, Ohio, Jefferson County, Kentucky, and Philadelphia. So this is another statistic that's pulled from the CDC that was released recently. And it says that 88.4% of all drug users in DC have encountered some sort of treatment or emergency service before their death. So that could be they were in treatment for a disorder, they had a pre-existing diagnosis, someone had witnessed them using before. And this is a pretty shocking statistic because you wouldn't expect that our drug use to be so high and then also have so many people in treatment or in some relational capacity to treatment. So these people aren't just coming out of the woodwork, as we know. They're high healthcare utilizers, right? We know who these people are. They've been using for a long time. And this statistic itself gives me a lot of hope because it means that all these people are in the system and we have access to them. And if we do the right thing, it means that we can actually solve this problem. Okay, so let's talk a little bit about why DC is unique in terms of its drug use population. DC is about 50% black, we know that. But around 84% of all overdoses in DC, all opioid overdoses, are from black patients. And that's a pretty ugly disparity right there. The other key point where DC is different than the national population is in terms of patient age. DC has a much older opioid use population. It's around 49 years old in DC versus 40 years old for the national average. And that might not sound like a lot, 9 years, but take another area of healthcare, heart attack. The rate of heart attacks per 100,000 people for someone aged 40 is around 20. For a person aged 50, it's around 97. So think about that when you consider the kinds of stresses people are putting on their nerve systems, and then scale that out over the entire drug use population in DC. It's very important. Of course, it's not uniform across DC. Different areas are going to have slightly different demographics of populations. For example, in wards 2 and 3, there's GW and Georgetown. It's going to be a slightly younger population. In addition, the chances that a person is going to overdose in their own residence changes based on where you are in DC. Between wards 2 and ward 8, the lowest and highest in terms of residential overdoses is a 25% difference. So this population isn't even uniform across DC. Forget about the country. So we have to keep that in mind when we're planning emergency response. So let's talk a little bit about DC geography, and then we'll wrap up with the demographics here. So I think we all understand where these overdoses tend to occur. Wards 8 and Ward 7 are shocking in their consistency. They're frequently the heavy hitters in terms of overdose. The biggest single area, is in that intersection of wards 5, 6, and 7, right there. And in fact, if you pull out the top 10 neighborhoods, about 50% of all cases can be accounted for in these top 10 neighborhoods. Number 1 being Trinidad, which is that intersection right there. And if we were to look at this in comparison to the number of people experiencing poverty, I don't think it takes a statistician to see the overlap here. Whether or not opioid use contributes to poverty or poverty contributes to overdose or vice versa, we don't really know at this point. But I think one thing that's important to note is that a lot of these areas, specifically a lot of the areas in Ward 8, you can see that darker area, is one of the biggest areas for public housing in DC. So that's important to consider when we look at where people are overdosing and why. Okay. So now to wrap up these statistics, now that we have a good idea of who's overdosing and where they're overdosing, let's talk about how this trend has changed over time so we can get a better idea of why overdose spikes occur at all. So in terms of non-lethal overdose, people not dying, that trend, it has gone up a little bit. There have been more non-lethal overdoses, but it's stayed relatively flat over the years, relatively, in comparison to lethal overdoses, which just continue to go up. And you can see this in the mortality rate, which is the ratio of non-lethal overdoses to lethal overdoses. And we can see that the mortality rate continues to increase. So why is this? Why do lethal overdoses go up while non-lethal overdoses stay relatively flat? You can see there are some spikes here that has to do with it being the summer. People tend to overdose more during the warmer months. Well, the reason, as some people might have guessed, is fentanyl. This is from the chief medical examiner. Since 2016, the overdose deaths involving fentanyl have gone up from 62% to 98%. All opioids in the district at this point can be considered to be contaminated with fentanyl. So now that we have this complete story, this complete picture, we can understand why spikes happen. We have this older population, this population that encounters healthcare frequently. They've been using safely, likely, for a long time. And now that there is this more lethal contaminant, this increase in fentanyl, it means that when there's a bad batch, or when someone uses as they normally would with a higher percentage of fentanyl than would be expecting, they die from it. And because it's not one person, one batch, it's several people, one batch, we get spikes when there is a contaminant like fentanyl or one of equivalent lethality. So the reason I was brought on to DC Health is so that I can take all of this information, this non-lethal information, so we don't need to wait for the fatal overdoses to come out, and it can respond to this problem in real time. And I'm going to talk a little bit how we do that, how we understand that information, and how we deliver it to the people that actually do emergency response. Okay, first thing we need to understand what exactly is an overdose spike. I'm not going to spend too long on this. The most important thing to take away here is that there are really two perspectives you could take on this. You could use raw numbers. You could say There are 10 overdoses in 24 hours. That's a lot for DC, right? But if you start breaking it down into certain areas of the population, some areas might use more frequently than others. This might not make as much sense. What we use is this second option here, which is using a curve. And all that does is it accounts for the rate over time and also adjusts to the rate of usage in specific areas. So I'm going to be talking about this specifically when I refer to a spike. So this is the process by which we get our information. First thing that happens, someone overdoses, they call 911, and FEMS responds. That information is automatically sent to DC Health servers, and it's forwarded to this service called ODMAP. Some people here might be familiar with ODMAP. It was started in Maryland in order to collect overdose information, and has this really cool feature where it uses those standard deviations that I highlighted before, those spike definitions, and it sends out an email to all the people on the list saying, hey, there's a spike going on in this area. So at this point, all 50 states, agencies in all 50 states have plugged into ODMAP, and they're now using as their spike response, including DC. So when there are, for example, 10 overdoses in a certain period of time, I, along with a whole bunch of other people in the DBH and DC Health and some community partners, will get an alert saying that there is a spike in DC. Now, there are a couple issues with this system that we're trying to work out right now. There's a delay from DC Health to ODMAP because we're transitioning the EMS system. And of course, the most glaring issue is that I can't generate these spike reports if I was hit by a bus. So we're trying to automate this process as well. The reason I need to make these spike reports at all is imagine you're receiving one of these notices, right? You get an email in your inbox that says DC is in a spike. Well, now what? Now what do you do with that information? I go in, I see that email, and I pull out all the locations, all the spikes, and all the demographics where people are. And then I compile it into a new report and say these are the specific intersections. These are the areas and the neighborhoods of DC where you need to go in order to respond to this overdose spike. Here's an example of one of the reports I can generate. They're really concise and really short, and they're meant to be put out very quickly. So it shows where the overdoses are, it shows where the key intersections are, and it breaks it out by neighborhood. So before, when people would just receive the spike, they would go, oh, we need, talk to your neighbor, we need to distribute naloxone broadly. Now we can say we need to go here and give naloxone to these people. This is where the spike report goes specifically. So I receive the email, I generate the spike report, and I send it to 3 specific agencies. First is Live Long DC. Some of you might be on the listserv. That'll go out to the media, to stakeholders like HIPS and Family Medical. And then also the DBH will get it. They have a mobile van, crisis response teams, DC peers. They have some people on the ground, which is great. And then the last group of people is I send it back to DC FEMS. They don't have an analytical unit inside the emergency medical system. So I'll send my report back to them, and then they can actually park ambulances in that area so that they can anticipate a response in that sense. Okay, so that gives you an idea of how we understand and how we act on spikes currently, but there's a lot that I want to do, and I think there's a lot of potential to actually alleviate this moving forward. So the first thing is we need to make the spike reporting better. There's some issues that I mentioned. We're going to improve those. I want there to be better communication regarding contamination. We have a lot of toxicology data. It's pretty consistent, and it should be made available. And then there should be more robust methods for making sure those people that are receiving care are sent to relevant treatment facilities. We need to understand who's dropping out when people are receiving care, who's refusing care when there's a spike and people are getting picked up. What kinds of people should we be looking for specifically? It might be the case that a whole bunch of students are overdosing, right? We need to say there are people under this age group. It's happening at this university, so on and so forth. And then right now, I think DC Health and the DVH are in the process of distributing fentanyl test strips, or at least going through the process of approval there. Like I said, all opioids now have fentanyl in them. This is more for cocaine use. So making sure that the people who are using cocaine aren't getting something that they didn't plan for and might die from. Okay, I did have a Q&A section planned, but I think I'm going to defer to Dr. Henderson here so she can elaborate on some of these final points. Thank you very much.
So, good morning. I'm not going to talk about Live Long DC, which is the actual campaign that goes along with opioids. That specific campaign is housed within DVH, or the Department of Behavioral Health, as my counterpart there actually leads that. My goal and objective today is to talk to you in general about communicating during a public health emergency and some of the steps and stages that any communicator, not only here within DC, but across the country, goes through, the steps and process that they take in order to develop a communications campaign and continue to evaluate their plan and that they use to improve their campaign in order to reach their target audience. So how it all begins. Ben gave us a very great presentation about everything that he does, all the work he does when it comes to opioids and looking at the crisis and all those components of persons that he actually reaches out to. At some point, we all come together, including the communications director or leads for these teams. We sit with the epidemiologists. We sit with those teams that are going out into the streets, those foot teams, anyone else who's doing any work. And we have a discussion about the data. So as a communicator, I also have to understand what's in the data, because I need to understand who our target audiences are and who do we need to reach. So I develop a strategy or a plan. That strategy or plan looks at what is the background information, what's in the data. I identify who are the target audiences, what are the messages, what do I need to try to tell them, what do I need to get them to do? Am I looking to increase knowledge and awareness? Am I looking to change a behavior of some sort? Am I just trying to get them to adapt or adopt or just change a way that they already have and are engaged in? Then I think about the outreach strategy, because under my team, I also have community outreach workers. So I do send them out into the community in order to reach those hard to reach folks. They know where they are in those spaces and places to even take information to them. So I can't just develop a plan that looks at using social media, looks at using TV, radio. A lot of people are not on those outlets or using those platforms. So I do have to have people on my team who know where to go in order to reach who we're trying to reach. So we do that. And also looking at collaborations, again, internally as well as externally to the organization or agency. So we come up with a plan. We execute the plan. We go back, look at the data. We don't see things changing in certain areas. So you go back to your plan and you say, and go back to yourself as a communicator or with your team and say, how do I reach those who seem to be hard to reach? So we probably are using the same traditional tactics or strategies in order to reach them. But then it causes you to have to think about what are those grassroots strategies that you may not have thought of that you can potentially implement here in this particular situation in order to get your information and message out. Now, I do have a few examples. Some of these examples are some of the things that we did during COVID, and I can also tell you that some of the strategies and tactics that I used during COVID, we are also leveraging now to use them for monkeypox. So one of the things that we did very early on during the release of vaccines during COVID-19, we launched a system for persons to pre-register. The pre-registration system, we heard a lot of feedback from the community, and I was able to see this through social media. Now, one of the techniques that we use within social media is also called social listening. Social listening helps me to hear residents or persons on what's happening in the community without having to go and specifically ask what's happening. So I'm listening to residents and those to understand what they need, what they want, and how to combat misinformation without even having to leave or go out anywhere or develop a survey to do so. Well, we heard the call from a lot of people. There are residents who don't, once again, have internet, those who did not have access to certain things. They didn't want to be a part of what they were calling the cattle call. They just didn't feel like they were able to get access. So what we did was partner with churches within the city, a part of a pilot study. And the beginning pilot study was to go into wards 5, 7, and 8, where vaccination rates were lower, to see if using this strategy would work to increase the number of vaccinations. I will say, in going physically to these sites, I would see a lot of persons who were seniors who were coming to be vaccinated. Also, churches have vans. They would go pick up seniors. Seniors could walk to these locations. They didn't have to try to figure out where to go in the city to get a vaccine because they knew their church, it was a trusted location. Trust is also a big deal and a big issue. If they also saw their pastors being vaccinated. So if I see the person who I am engaged with from Sunday to Sunday and who I trust doing it, it should be good for me. So that's what we saw. And then later on, we expanded this to going to houses of worship, where a lot of residents who are limited English proficient or non-English proficient were going. You would have thought that we may not have put out any messaging. No, I have my staff, and one of my staff is here today, who was flooding the city with messaging of where to go, how to find it. But when I tell you we were going to these churches where they were actually serving persons whose first language was not English, and you saw large numbers of residents coming to be vaccinated. Once again, houses of worship serve as a safe haven and a trusted place, so they were coming to get vaccinated. When it came time to reach youth and young adults, one of the things I knew was youth and young adults speak a different language. They don't speak the same way I speak. I don't know how they speak. I don't know their jargon. So I can't assume I know that my messaging is just going to get to them because I'm a communicator. That doesn't work. In order to understand how to communicate with young people, you have to ask them and engage them to help them know that they have a valid voice, they matter, and we want to hear from them. Luckily for us, a couple of things that we had in place already within DC Health, there are some youth advisory councils within a couple of our administrations. So we reached out to those young people that we already had access to, just to ask them, how should we communicate about COVID to youth and young adults? The one thing they told us, you can have the same messaging, but it needs to look like you're talking to us. Because right now it seems like you're only talking to our parents and our grandparents. So we took that as one component. I also developed a youth and young adult advisory council for COVID-19. And through that, we had some competition, some competitive times, while developed them to become those experts that we could use and leverage to talk about COVID. We also had them develop TikTok videos. So we developed a TikTok account as well. And as they developed those TikTok videos, they were the ones who were talking more about COVID-19 and the impact and influence of it. So this is a photo of one of the young men who actually created a TikTok that we actually put on our account. So people could see young people talking about COVID and not just us or say the director of the agency. Another component was to use everyday people in our messaging. It's one thing to get images from a stock photo repository, but when you have real people who are in your neighborhoods that you see and know, and you can see their personal testimony and their story, they become walking billboards as well. I had a lot of people talk to some of their friends and be like, I saw you on the side of a bus. I was in my car and I looked up and there you were. But then people started putting it on their Facebook pages. Without knowing that they were actually promoting and helping us to promote, they were. So they became also messengers, incredible messengers at the same time. Using culturally appropriate materials and messages. We also partnered with our sister agencies within the Mayor's Office of Latino Affairs, African Affairs, and Asian and Pacific Islander Affairs, and came up with videos of trusted messengers. So we reached out to them and identified who were those trusted messengers within each one of those communities and had them come in and record messages. If persons aren't listening to you, they once again will listen to that trusted messenger. So making sure you have culturally relevant and appropriate messaging is always important, and not just translating words from English into other languages, because you lose the message when you do that. The other thing was to be unexpected. Typically, you would find us on a bus, on the radio, places of that nature. Well, now you could find us at Washington National Games, where we would have large groups of people. And that campaign was talking about childhood vaccinations, sort of like the back to school vaccination components. We were in movie theaters. So before the movie starts, you have those various preview commercials. We were one of those people. In the grocery stores, and then even the 7-Elevens, and that's an image of the 7-Eleven ATM. So we were everywhere. And then, once again, remaining a trusted information source and, once again, listening to our audience. And I talked about using social listening. So we came up with Myth-Busting Monday, Wisdom Wednesday, and those are themes that we use on our TikTok. And we have various TikToks on that. And then we have a series called Let's Talk About It. Let's Talk About It is not only in English, but we also have it in Espanol. And on next Wednesday, we're actually doing a Let's Talk About It in Espanol on monkeypox. The questions from our persons who speak English or speak Spanish as their first language have different questions because monkeypox has a different effect on them than what it does for those of us who may speak English. So that's the end of my presentation. Thank you.
Awesome. Okay, cool. Thank you, Ben and Dr. Henderson. Those were great. I'll turn this off. Those were great presentations. So now I think we have about 13 minutes, so we'll open it up to questions. And I will hand you all this. It's on mute right now, but if you just press that and it goes to green, then you're good to talk. So I can come back here for the first question.
Good morning. First of all, Dr. Henderson, thank you. I work with Dr. Henderson, and I have to just say the yeoman's job that DC Health did on COVID and what she explained. They didn't just work with churches, they also worked with community-based organizations, and they often adapted on the fly, and they were able to adapt fairly quickly. So I've said before that DC, I'd rather be, I wouldn't want to be nowhere else during the COVID outbreak than in DC, because our health department did exactly what it was supposed to do. It wasn't perfect, it's not going to be perfect, but they did better than anyone else that I know of around the country, and that's a testament to them. Outreach and communications, and this is both for you, Dr. Henderson, and for Ben. Ben, we've been on several calls together. There is the alert system that the District of Columbia has. I get alerts all the time on car crashes, road work, all kinds of different things. Can we, in some way, have a health alert using the same outreach to the same people? And people can opt out if they don't want to get the health alert, but to do a health alert, whether or not it's a monkeypox outbreak, whether or not it is a opioid spike, and to communicate with people that way as well. Because Ben, you and I, we've been in conversations talking about what kind of alert system do we need to have from the community side. You definitely mentioned that Live Long DC gets it, and then a couple of agencies and HIPS gets it, but community organizations should get it as well. And if they're not on the Live Long DC listserv, then they're not going to get it. And I'm saying, well, sidestep that include that, but also use the alert system that DC already had, the infrastructure that's already there. Ben, I wanted to talk about one of your slides, which talks about 88% of drug users encountered at least one potential opportunity for intervention. And I wanted to get a sense from you, what does potential opportunity for intervention mean? Does that mean that someone touched them, or that there was the potential for someone? Because those are two different things. And so there could be a potential because someone's in the house. That doesn't necessarily mean that they actually touched them. So are you measuring touches, or are you measuring actual interventions or potential interventions?
Thanks for that question. I think it was two questions, actually. I'll take the second one, and I can hand it off to you. For the second one, in terms of potential interventions, what they're counting is all of those measures you saw on that slide. So whether they had a diagnosis, whether they were in current treatment, it meant they had at least one point of contact with the healthcare system in reference to substance abuse. So they know there was a substance abuser in the system, and they had the potential to get treatment before they had a fatal overdose.
Right. And to your first question, Ambrose, I have personally been looking at how we at DC Health can use a system, and not necessarily an alert system, but looking at how we can use text messaging for people to opt in and opt out of for specific health issues or concerns that we do cover at DC Health. We've been trying to look into that platform for about 6 or 7 months now. We've had some issues on the side with the vendor a little bit, but we're still working on that to see what we can do. But the alert system you're actually talking about, I would have to sit with HCMA to see how we could actually use that alert system for that particular purpose as well.
My name is Marcus Webster. I'm with Voices of Hope. We are in Hartford and Cecil County in Maryland. I had two questions, both for Ben. One, if you could explain the gap in the trends of overdoses from September 2019 to January 2020. And the second question I have, in our region, we're seeing a significant spike in xylazine. So I wanted to see if that's something that you guys are beginning to identify and address here as well.
Yeah, regarding the first one, that was just a systems error from FEMS. They recently switched to a new system around 2019, and then that was just an issue with reporting. The numbers were very weird. It wasn't worth including just because there's error there. In terms of xylazine, there have been individual cases we've seen. There hasn't been a surge like people are seeing in Philadelphia, for example. So it hasn't hit here just yet.
Good afternoon, or still morning. Great presentation, both people. My name is Dr. Ursula Pearsall. I'm with Prestige Healthcare Resources, and I have two questions. First is there any way to receive your current data that you had on the slides? Can you email them out to us? Can you get a copy some kind of way? She's nodding with me. We have and we have 2 or more, so we're good. If we can get those, we'd be grateful. I'm really looking into the youth component, and because I've been in substance use for about 28 years. I'm retired military. I've been in combat 4 times. And so, of course, we know substance use may be used for different reasons. The effect of it is so impactful to the family as a whole, holistic approach. And so, with the peers that we're working with now for our DCOR grant, I'm seeing the youth be more effective. And I was hoping that, I know now there's some money to, pay peers, the adult ones, but if we could have some money in the schools for the youth peers. I believe that identification, because we do have a large population of youth that were addicted to substances that are now fighting and struggling to be clean. And when I say youth, not just teenagers, up until college, that college age, I think that could be very, very effective. And I was wondering if any data was being taken for that. The slash or the caveat into that, I did a lot of work on the COVID epidemic. And I noticed the contact tracing component. I know we knew about the adults, but did we also track the youth that were at home? Exactly, because I used to create formulas for people that were addicted to substances, and so that's always like in my brain, like what are we doing? Because that like re-engaging over and over and over. And the last thing of my thesis, and I was talking earlier about it, we've been getting a lot of interest from the gym about giving information about monkeypox, and so I was hoping that maybe some data could be sent around to some of the local gyms with the sweating and perfusion and the high rate spikes in DC, because what it does, it trickles down to our population with the mental health and things of that nature. You would be amazed at some of the sessions that I've heard in the past month about the returning to monkeys. We're literally, it's a paranoia. It sounds funny, but someone could really be thinking about it. So I've said a lot, but most importantly, the data. That's what we really want to wrap around.
Yeah, I am always happy to work with members of the community. If you guys want to come talk to me afterwards, I'll give you my email. We can discuss transferring some of that information over. I'd also like to hear more about your youth outreach and youth prevention measures. We're seeing a slight downturn in the average age of overdose recently, so I want to understand why that's happening, and I feel like you guys might have some insight into that. In terms of the communication during COVID, I think Dr. Henderson would actually be a better person to answer that question.
So can you ask your question one more time? I heard COVID, then I heard monkeypox. And
So with COVID, I know we had the tracers with the family component with the parents.
right.
Was any of that data done with the children, like how many children were in the household, if anybody contracted COVID in that manner? That came up because it was a story that was going around about an infant that had contracted monkeypox, and my population just like went crazy with it. And so I was just wondering, are we breaking down the data to the least common denominator? I know the funding is not there. I know you all, pay for it up front, and they said it's an epidemic. We may get some money back. I understand all of that, but yeah, I still ask.
So I can actually work with our state epidemiologist to get some information about that for you, because there were a lot of different things that we looked at with COVID, and looking at monkeypox is slightly different because it's a different type of virus and situation. Because traditionally monkeypox, especially within the eight to 9 countries where it is an endemic, monkeypox looks totally different than what it does look now for the countries where we haven't seen monkeypox probably ever, or for the first time. So it's a totally different thing that we're dealing with and trying to learn at the same time. And that's the same thing that happened when COVID first came out. We were trying to learn. So we would have to give a little bit further discussion or have some additional discussion to understand how it is transferred, especially when we start talking about children and young children, because I actually know what you're talking about. And sometimes it's not necessarily monkeypox all the time. There was a time where it was just foot, mouth, and disease. So with a child. So anytime a person now is seeing a rash, they have become on alert. And all rashes don't necessarily mean that they're monkeypox. They could be something else. So the goal and objective really is to make sure you have a healthcare provider and to seek care immediately if you see something different or unusual, so that you can understand what it is. But I can give you my contact information, and we can get your question up to our state epidemiologist. You're welcome.
Awesome. I think we have one more question, and then we'll break for lunch.
Yeah, hi. It's good to see you both in person and not just on the phone or Zoom or whatever. I'm Daryl, and so I wanted to just echo what Ambrose said about the alert system that exists, because I'm getting them all the time about the water is off on street number so-and-so and da-da-da. So the system may already exist, and it may be less than finding something else, because many of us are getting that. But whatever system you use, I wanted to just suggest that not just alert about it happening, but alerts that tell people what to do in response to it. Because I think we get a notice that says, hey, there's a street light out somewhere, but that doesn't tell us if you need to go that way, or if they're detouring, or why, it doesn't give us any more information, just a fact to wait, right? And that's not as helpful as to say, now this is happening, this is what you should do, right? For the people that are getting those alerts. that I wanted to ask, Ben, in your conversation around the cocaine and the opioids, the question I also had, because I see a lot of alcohol use in our communities as well, in the communities that I'm working with, and I'm wondering whether or not any of your data, or if alcohol is just such a common thing like cigarette smoking that it's not included or a factor, but what is the factor maybe of alcohol that also exacerbates this cocaine and opioid usage and compromising folks to a place where they are more subject to these kinds of things? And has there been any linkage, and you may not have this information right now, any linkage to then HIV infections or other kinds of infections that are happening as a result of people doing more of these combination drug circumstances, situations? I'll leave it there.
So to answer your question regarding the alcohol use is absolutely included when we're taking a look at co-substance use. The reason that cocaine was pulled out specifically is just because cocaine and opioids are a uniquely lethal combination. It's really, really bad to take those two together. Alcohol and opioids, still bad, not as bad. So it's not usually as indicated. And to your point, you're right, it is just really widespread. So usually if the medical examiner sees alcohol in their system and opioids in their system, they're probably going to point to opioids and say it was that. If it's opioids and cocaine, they'll point to the opioids and cocaine and say it was that. Alcohol maybe might fall under the radar for that. In terms of HIV, the only statistic I can remember right now is when I was doing research at the psychiatric hospital, around 3% of inpatient opioid users had HIV, which is pretty high. And that just has to do with the needle sharing, which everyone here is aware of. In terms of the actual exacerbation of that with alcohol is something I would have to look into. Did you have a second question? There was a second part to that? Okay.
Awesome. So yeah.
So with your Mr. Ben, Mr. I just want to know if that statistics is just like a whole population, or if of older population, or it also older population that doesn't include any of those youth that I am interested. So it's all on the older age population.
Awesome. Well, if we could give Ben and Dr. Henderson a round of applause. They did such a great job. Now we're going to break.